How are you? It's nice. I wanted to thank the opportunity to speak at the International Metabolic on cardiometabolic disease, obesity, and diabetes meeting. I wanted to thank personally to Professor Kotsis who sent the invitation to me, and I would like during this morning to talk to you about the subject that I was proposed to speak about, which is the extremes in vascular aging. I think you can see my screen share right now.
Yes, no problem.
Okay, perfect. So just see if we can move forward. There you go. These are my current affiliations. I have no conflicts of interest in regards to this presentation, and I decided to divide this topic in four particular subjects that I will be discussing with you today, and that we will go through to characterize both extremes in vascular aging and the new possibilities of pulse-wave velocity as a treatment target. The first paradigm is, of course, a change that we've experienced throughout the years, from moving from looking at one of our patients just on the road to end-stage heart and renal disease through the cardiovascular atherosclerotic continuum that you will see appearing on the left-hand side of your panel. And this cardiovascular continuum was later on completed by Zhao, Rourke, and Safar in 2010 by adding it a cardiovascular aging continuum, where, of course, many of the changes in the aortic medial layer of large arteries occurs through mechanic stress, changing its ability to continuously buffer and absorb the energy at each cardiac cycle and transforming pulsatile blood flow into laminar blood flow that will later on be sent into the arteries, smaller arteries, in organ damages. So these two cardiovascular continuums, in fact, complement themselves. As on one side, you will have the action of cardiovascular risk factors to development of atheroma, plaque, and then finally thrombotic manifestations of cardiovascular disease. And on this side, you will look at a progressive loss of function in elasticity and its consequences occurring with hypertrophy, increased left ventricular work, myocardial impaired myocardial demand, myocardial ischemia, and then a whole sequence of cardiovascular disease. This is, in fact, a lighter reproduction of the same. In the upper panel, whilst you have young and healthy arteries, the heart will pump and the energy and pulse wave will travel through the aorta, but its energy will be absorbed and reflected back from the microcirculation, so that when the blood flow enters the microcirculation, it will be laminar and with low energy in order not to harm the conductance vessels of organ damages like the brain and the kidney. This does not happen as we age, and as this elastic properties, buffer properties of the artery is lost, and all the pulsatile energy that the heart produces is not absorbed and is somehow not transformed into a laminar flow, and then pulsatile load is transmitted into the microcirculation. Nowadays, we are measuring this arterial stiffness or loss of distance stability through carotid femoral pulse wave velocity, as you can see here, and this has become an independent cardiovascular risk marker to the development of cardiovascular disease, cardiovascular mortality, and all-cause mortality indeed. So in fact, if you have an increase by 1 standard deviation of pulse wave velocity, you'll have a concurrent increase by 42 to 47% in cardiovascular risk in different outcomes. This was early recognized by the colleagues working in the cardiology field and in heart failure, understanding that the ventricular arterial coupling was also influenced by the fact that you have more or less elastic arteries, increasing the workload that the heart has to perform in order to complete the cardiac cycle and promote the appearance of every forward wave at the beginning of each cycle. And therefore, the European Society of Cardiology and the Heart Failure Association have in fact included pulse wave velocity at the heart, at the mechanistic heart of the development of cardiovascular disease, several cardiovascular diseases, mainly subendocardial ischemia and heart failed either with preserved ejection fraction or with reduced ejection fraction. So having understood how vascular aging is promoting changes in the cardiovascular field, we will set with a different paradigm, the paradigm of how do our arteries age, and how can we match the way that they age with the appearance of different phenotypes that are more or less prone to cardiovascular disease. And this is how the extremes in cardiovascular disease began. Firstly, we should note that pulse wave velocity and arterial stiffness above 10 meters per second has been documented as the most prevalent hypertension-mediated organ damage in the Framingham Heart Study and then confirmed in other studies. So 40 to 60% of our hypertensive subjects do have hypertension, do have arterial stiffness, and if we do not measure it, they will be underdiagnosed and undertreated because their risk will not be conveniently stratified. The second important thing is that there is a continuum, a longitudinal continuum, and to the influence that arterial stiffness promotes. And to the core topic of this conference, you can see here that pulse wave velocity and arterial stiffness above 10 meters per second not only is a promoter of disease, of cardiovascular disease and chronic disease, but also is involved in the mechanism of cardiometabolic disease like hypertension and diabetes, which altogether decrease the level of vascular health of a subject. And finally, pulse wave velocity and arterial stiffness are not only hypertension-mediated organ damage, but they are also one of the main mediators of the effect of organ damage to the final cardiovascular disease development, and therefore they have more than just target organ damage importance. They are at the same time influences of the activity that leads to cardiovascular disease through other target organ damages. And I will keep these two in for the sake of time. So how did we get to develop and to understand what are extremes in cardiovascular aging? Well, in 2010, Cunha and colleagues in the reference values for arterial stiffness collaboration were able to publish the normal values of pulse wave velocity for each age and sex, so that we knew what were the normal values of arterial stiffness and the changes that were normal and expected to see for a given patient at a given age. So whenever this value was above what was expected, we knew that these patients were having accelerated changes in their vascular system, or otherwise, if they were below these values, they were being able to preserve the function of their vascular system as it were years before. And so this allowed us to understand that we could divide actually subjects that were having an accelerated vascular aging, whose arterial vascular system was degrading faster through the action of both age and the interaction with cardiovascular risk factors. And therefore, they were coming into a vascular system, an arterial system that was several years older biologically than they are, and they did not correspond to the chronological age of a subject. This also means that for a subject at a given age with older arteries, the risk of having cardiovascular events would be the same as someone who would have a healthy aging and was at that chronological age. So in fact, risk of cardiovascular disease would come earlier than expected for that subject. And this is how the early vascular aging idea and concept was born. And we ourselves looked into the prevalence of this early vascular aging system, classifying 3,038 subjects of the population in the north of Portugal as having pulse wave velocity above the 97.5th percentile of the pulse wave distribution, only to find that in average 12.5% of the population have early vascular aging. But more worrisome were the numbers that we found in younger people below 39, where 12.8 and 26.1% of the population already had changes of accelerated vascular aging, no doubt in line with the excess in cardiometabolic disease, dyslipidemia, and hypertension that we were registered in these age groups. But the Framingham Heart Group has gone farther, classifying healthy vascular aging as those subjects that were able to keep pulse wave velocity as they were, as when they had 30 years, below 7.6 meters per second, no hypertension. And then they looked not only at how many patients did they have with this feature of healthy vascular aging. Looking here, only 1/3 of the population between 50 and 59 preserved a good arterial function. And more importantly, when you compare healthy vascular aging with the rest of the sample, there was, in a follow-up study, there was a 55% decrease in risk of developing cardiovascular disease for these patients who preserved good arterial health. In the MARI study, a consortium of 18 studies and approximately 16,000 subjects, we also compared healthy vascular aging and early vascular aging as the extremes of the distribution in the population of these 18 studies, only to find out that for patients aged 64 and that kept no cardiovascular disease and healthy vascular aging, their biological age was in fact the same as younger healthy subjects with 30 to 49 years, which means in fact that people that had early vascular aging had arteries that were 14 years younger than the people that were that the chronological age of people. And this also carried significance in terms of reduction of risk of cardiovascular disease. And finally, supernova. Supernova is a term that comes from the astronomy, and that shows you that when a supernova star bursts, it becomes one of two things: a black hole and a neutrino star. And within the black hole, time does not pass by, so you do not have the changes of the structure that would occur with time in the arteries. And this is the same with these individuals that have supernormal vascular aging or supernova. In fact, time passes and they preserve the same arterial and vascular function that they had earlier. And recently, a study done using the reference values collaboration and Malmo diet and cancer cohort could show that patients with early vascular aging, integrating not only the pulse wave velocity that they present, but also the influence of different cardiovascular risk factors, the ones that actually had early vascular aging, healthy vascular aging, when they were compared to healthy vascular aging, this would mean that they would have a reduction of about 50% in the risk of developing cardiovascular disease. So, in fact, we were able to constitute a whole range of 4 phenotypes of vascular aging, 2 of which have a clear prognostic significance and a higher or lower incidence of cardiovascular disease, whether you're talking of early vascular aging and supernova or healthy vascular aging. So the final issue I wanted to discuss to you about is, can you treat arterial stiffness, and does this reverse changes that occur mainly in patients with early vascular aging? Well, this was the only randomized control trial that has been developed to answer that question. Unfortunately, it was underpowered because the recruitment was not the one that anticipated earlier. And so the primary outcome of reducing outcomes was not achieved during the study. But several other issues could be seen, the first of which was that through a direct treatment of arterial stiffness, you could in fact reduce the early vascular aging, the vascular aging of these subjects and control better their blood pressure. But some other indirect evidence has come from the SPRINT study, showing that in the intensively treated group, the ones that benefited with reduced outcomes were the ones that had concurrent reduction in estimated pulse rate velocity. And finally, the most important evidence of the SPRINT heart study, where in fact pulse rate velocity was measured accordingly, and the differences in mechanical and biologic changes in aorta were measured through MRI, only to show that subjects treated after follow-up more intensively had a reduction in their pulse rate velocity and in fact a reduction in cardiovascular events, even though the number was significantly low and not enough to be externally validated yet and transported into clinical practice. So there was a reduction in 56% of events, and this was the first time that significantly you could show that treating directly arterial stiffness could in fact reduce the probability of having cardiovascular disease and cardiovascular events. And finally, my last slide, people treated and reducing arterial stiffness do have a concurrent reduction also in left ventricular structure, and we all know the cardiovascular risk meaning that this purports. So to conclude, I have shown you 4 phenotypes of cardiovascular of extremes in cardiovascular aging occurring from chronobiologic asynchrony, and with particular importance given to early and vascular and healthy vascular aging, as they purport a number of different cardiovascular risk significance. And I would invite you to come soon to, not in March 2023, but in March 2024, to the Arterial Stiffness and Early Vascular Aging School that we organize in Minho University, and to be in the lookout for the second edition of this Early Vascular Aging book that we are hoping to put out soon. Finally, to invite you to come back home to Guimarães and to enjoy our company as much as we would enjoy yours. Thank you very much.